Unmuted.
11 people are there.
One, sir. One. Only me.
Oh,
Abhishek.
Okay.
So the last class we spoke about different new immunosuppressants that have come up according to the 2020 update. Your rituximab, what are the recommendations of giving methotrexate and eculizumab? So eculizumab, we spoke that it is given current now, it's the FDA approved drug approved in 2017 and indicated only for severe refractory AChR antibody positive generalized myasthenia gravis because the complement system is only active in AChR antibody positive myasthenia gravis. So, but still, even though this has been FDA approved, we need to think before we give this treatment, the cost and efficacy with other treatments need to be compared and then proceeded with giving. The important thing that we need to remember is before starting eculizumab, we need to vaccinate the patients for meningococcal meningitis 2 weeks before the infusion. So we have to give all the serotypes. That is, there are two vaccines. One is the ACWY conjugate and the other one is a serogroup B conjugate. Both needs to be given. Then currently it's approved only for refractory AChR antibody generalized myasthenia. So we need to look at other populations, efficacy in other populations. And how long do we have to give the therapy? Those all studies need to be conducted. Now coming to IVIG and Plex. When do we give this? What are the indications for giving IVIG and Plex? Life-threatening signs. Bulbar, ventilatory. If involvement of any of that, we need to give IVIG and or Plex. Then in preparation for surgery in patients, important only with significant bulbar dysfunction. So when a rapid response or when a rapid response for treatment is needed. We can also plan for IVIG or Plex when other treatments are insufficiently effective. And then sometimes in patients with acute symptoms like who have ventilator dysphagia, when we give corticosteroids, initially it takes some time to act. We saw that it takes around 3 weeks for it to come into effect. So during that time, there can be transient worsening caused by corticosteroids. So prior to beginning corticosteroids, if deemed necessary, to minimize the exacerbation. Now, again, what do we choose? It is found that both IVIG and Plex are equally effective and in the treatment of severe generalized myasthenia gravis. So we need to individualize this. So we need to look at the patient and see what is best for the patient. There are some, so for example, we can't use IVIG in patients who have just had a recent ischemic attack. So because it can cause hypercoagulability. And if the patient has sepsis, we can't put in more lines and cause more sepsis or disseminate it. And the other thing is IVIG's, the efficacy of it is not been well established in cases of milder myasthenia gravis or ocular myasthenia gravis. In musk myasthenia gravis, Plex is preferred. But one more thing that has been mentioned, which I'll be mentioning, that according to expert consensus, this is not regarding any study, they have just observed and found out that Plex is better than IVIG, though the both are effective according to the studies. So the use of IVIG as maintenance therapy can be considered for patients with refractory myasthenia gravis or for those in whom immunosuppressive agents are contraindicated. So how do we manage impending and manifest myasthenic gravis? So initially we saw the definitions and now we are looking at management. So they are emergent situations requiring aggressive management and supportive care. So in these conditions, we need to rule out a cholinergic crisis. So even though it's become rare now, and also we need to think about whether a pyridostigmine or neostigmine is required in these cases because they can cause tube blocks or mucus plugs. They increase the secretion. In a patient who already has difficulty breathing, will be worsening their symptoms. So their mainstay is through Plex and IVIG in managing these conditions. Impending crisis, myasthenic crisis. How have they defined it? Impending crisis, what should we do? Requires hospital admission and close observation of respiratory and bulbar function with the ability to transfer to an ICU if they manifest crisis. Myasthenic crisis requires admission in an ICU or a step-down unit to monitor and manage respiratory failure. Here we are just monitoring, here we are managing respiratory and bulbar dysfunction. So they are both short-term treatment in the management of myasthenic crisis and impending myasthenic crisis in patients with significant respiratory bulbar dysfunction. Corticosteroids and other immunosuppressants are often started at the same time. This is what I was talking about. You can delay the initiation of corticosteroids by a couple of days if the patient is in manifest crisis after initiating Plex to IVIG. So that's what this is the expert consensus telling that Plex is better than more effective and works more quickly. So now we'll be talking about thymectomy. So in non-thymomatous myasthenia gravis, so what are the goals of doing a thymectomy?
IVIG, how much? Plex, how much?
So 2 gram per kg body weight to be given over 4 to 5 days. Plex, we can give 5 sessions on alternate days. This is according to them.
What do you mean by 5 sessions?
The dose, sir. That I'm not sure. 50 ml per kg.
You only saw a patient. No? How many sessions were given to her?
We had given initially she was given 7 sessions, and here we gave 3 sessions.
So is there a limit? Like you stop at 5, you don't go above 5.
Nothing like that, sir. Give till the symptoms improve.
Yeah. So how much is the dose?
50 ml per kg body weight is what we're following here for GB. I don't know for myasthenia how much we're giving.
Total body water, based upon the total body water, we'll give saving the body volume water into 5 sessions. Each volume has at least one total body water session. It can be given by FFP or albumin.
We're giving an albumin, sir.
Okay, 50 ml per kg. That was one session.
One session is
50 ml. So in non-thymomatous myasthenia gravis, an option to potentially avoid or minimize the dose and duration of immunotherapy. So the goals of doing a thymectomy are 3 things. One is remission. Second thing is reduce the immunosuppressive dose. Third thing is to prevent generalization from ocular to generalized. These are the goals. If the patient, so here the first goal is to minimize the dose as well as the duration of immunosuppressive immunotherapy. And if the patient fails to respond to an initial trial of immunotherapy or have intolerable side effects to it, also we can proceed with thymectomy. So this is an elective procedure. It takes some time to work. So patient needs to be stable and should be in a position to undergo surgery before proceeding with thymectomy. So in patients who are pre-pubertal, the whether thymectomy is useful or not is not clear, but we can proceed in patients with AChR antibody positive myasthenia gravis generalized. When should we do? In pre-pubertal patient, that is juvenile. One, if the response to pyridostigmine and immunosuppressive therapy is unsatisfactory, or to avoid complications of immunosuppressive therapy, including steroids. So if the patient does not have an AChR antibody positive myasthenia gravis, that is seronegative, then we need to look at other possibilities before we consider thymectomy, like congenital myasthenic syndrome and other neuromuscular conditions.
Is it proven in any other types of myasthenia gravis?
LRP agrin, it's not being proved.
So basically, you put only in AChR positive patients. Like all other types of thymectomy.
19 granulin receptor.
Is there studies to show it works?
There are definite benefits with AChR positive, chitin and anti-granulin receptor.
It's that I'm not read about it.
Why you have not read?
Because it does not at least only the studies probably prove, but it's not in the guidelines yet.
Are you sure?
Yes. Yes.
Chitin positive and alone. Granulin alone.
Can be.
They mentioned only these 3, sir. MuSK, LRP, agrin antibodies that are specifically named and mentioned in the consensus statement. They have not specifically mentioned that it's possible. So, and also what sir had asked the other time about elderly patients undergoing with thymoma proceeding with thymectomy can proceed. All patients who have thymoma they should undergo thymectomy. It has proven that it is effective, but the remission rates is not that good, but there is improvement in symptoms as well as reduction in the dose of immunosuppression. And the approach that we need to proceed with in elderly patients is the minimally invasive but extensive thymectomy.
In everybody, it has to be extensive.
Extensive thymectomy.
You cannot leave behind any remnants.
Yes.
And all patients with thymic enlargement should undergo thymectomy. Because before removal, you do not know whether it is hyperplasia or thymus. So you just remove any enlarged thymus in anybody. If thymic enlargement is there, you're going to remove even in, most likely even in
other
antibodies
also.
Musk also we can.
If there's a thymic enlargement, then you don't want to know.
Carcinoma is a possibility for that indication.
You have to remove it.
In elderly patients, the patient is not really, they can't undergo surgeries in elderly and comorbid patients. In those patients also, we need to treat the thymic enlargement with palliation, with chemotherapy.
Non-surgical measures. Then also you can do.
Thymoma too. So that's what's mentioned here.
Thymoma you probably remove even in someone without myasthenia.
Yes.
Some screening shows up an enlargement. You are most likely going to remove it. So I think once you see a thymic enlargement, elderly or not, if there's surgical effect, they should undergo removal of the thymus. The question only comes in those where you do not have thymic enlargement. Then antibody becomes important, age becomes important. Then only we are going to pick and choose.
So the recommendations say 45 years, but we can do up to 60 years. According to many studies they've taken patients up to 60 years.
Yeah, 60 has been, followed a lot. I do not know 45 when it came up.
Given a chart in up to date, less than 50 thymectomy, 50 to 65 years if it's a generalized
with
myasthenia which is not responding to
immunosuppressive.
You can try.
Maybe well-controlled patients we can leave it above 50.
Yeah.
But thymoma is
50 to 60.
Not thymoma.
AChR antibody positive.
There is no discussion with thymoma. Okay. Thymic enlargement, remove.
Right, that's what here also. So all patients with myasthenia gravis with thymoma should undergo surgery to remove the tumor.
But we don't know that. We don't know it's thymoma. Hardly anybody biopsies it.
No.
It is directly removed. Okay. So you will go with presumed thymoma and you remove it.
So after thymoma also, whether to go with additional or whether radiation chemotherapy is required or not based on histological. So is that the biopsy? So this thymoma, you might not see any improvement in symptoms immediately, or otherwise also, that's what it says. There is deposition of these antigens in peripheral lymphoid system as well. So just by removing the thymoma, we might not see an improvement in symptoms. We can't inform that they'll be completely rid of the disease. So further treatment of thymoma will be dictated by histological classification and degree of surgical excision. Incompletely resected thymoma should be managed with radiotherapy and chemotherapy. In multimorbid patients with thymoma, palliative radiation therapy can be considered. So small thymomas may be followed without treatment unless they are enlarging or becoming symptomatic. Two approaches: endoscopic and robotic approach and open approach. So at all points of time, they are found to have a good track record. In the sense, again, this is more of an expert consensus. And there are not many studies. So there has never been a studies where they've compared these two studies. So it's just that multiple studies they've taken and they've made a comparison and they found out this is a better approach. So thymectomy may be considered in patients with generalized myasthenia gravis without AChR antibodies if they fail to respond to adequate immunosuppressive therapy or to avoid or minimize intolerable side effects to immunosuppressive therapy. So current evidence does not support thymectomy for these.
So seronegative, but totally seronegative. Not MuSK, LRP4 or agrin also. But if they're titin or ryanodine positive, he's saying it can be done. Okay.
Only if thymoma is present, or
thymoma, there is no question. You have to remove it.
No, like if there is a hyperplasia, if
you
can see the thymus, remove.
Okay.
Most whatever you can't say whether it is thymoma or thymic.
So According to the 2020 update, in non-thymomatous generalized myasthenia gravis with AChR antibody, 18 to 50 thymectomy should be considered early in the disease. That's all they say. Early. In these patients, less than 50 should consider early in the disease to improve clinical outcomes and minimize immunotherapy. So thymectomy should be strongly considered in patients with AChR antibody positive generalized myasthenia gravis if they fail to respond to an inadequate initial adequate trial of immunotherapy or have intolerable side effects. That's what this is. So juvenile myasthenia gravis, immunosuppression is not really warranted in the sense they usually go into spontaneous remission. So in such cases, only if they don't respond to an adequate trial of pyridostigmine, we can proceed with giving an immunotherapy. And the problem with these patients is there's a lot of side effects. Even in like steroids have a lot of side effects in children because it causes early ossification of the metaphyseal growth plates. So steroid side effects include growth failure, poor bone mineralization, and susceptibility to infection. So what we should do, even if they require an immunotherapy, then the lowest effective dose with minimal side effects should be given. Here, if they're not really, like I mentioned before in Plex and IVIG, if they are not willing or if you want to reduce the use of corticosteroids or to avoid the side effects, they can proceed with Plex or IVIG as alternative immunosuppression. What do we do with MuSK antibodies? We have already discussed this. Pyridostigmine really does not work. Even in small doses, they usually have side effects. And then in such patients, they respond well to corticosteroids, but they have to be on corticosteroids for a really long time. We will be unable to wean them off corticosteroids. Here, Plex is a better option than IVIG. Then rituximab can be offered early in these patients. So myasthenia gravis in pregnancy. So what do we do? So planning for pregnancy should be instituted well in advance for optimization of myasthenia clinical status and minimize the risk factors. So here, if the myasthenia gravis is under good control, so then we can assure the mother that it will be fine and it will be an uneventful pregnancy. Most of the time, the worsening occurs post-delivery. So first few months after delivery. Here, how do we manage? Oral pyridostigmine is the first line of pregnancy, first line of treatment. If we give neostigmine, then it's a problem because it causes uterine contraction. So we need to avoid it as much as possible. So oral pyridostigmine can be used. And for avoid thymectomy should be postponed until after surgery. It's an elective procedure. Chest CT without contrast only if it is absolutely required. Pros and cons needs to be explained to the family before we proceed with it. Unless there is a compelling indication, postponement of diagnostic CT until after delivery is preferable. What is the immunosuppression of choice? Prednisolone. What are the other immunosuppression? If prednisolone is not giving an adequate effect, is azathioprine and cyclosporin. The two M's, MMF and methotrexate, are contraindicated in pregnancy. So this is the consensus, but there are a group of people who are against giving azathioprine as well for such patients. So Plex or IVIG are useful when a prompt, although temporary response is required during pregnancy. But again, the risk of infection needs to be explained to the mother. Again, vaginal delivery should be the objective and should be encouraged. In cases of eclampsia, avoid magnesium sulfate because it causes worsening of myasthenia. It has neuromuscular blocking. Initial drugs to avoid, I mentioned that magnesium is to be avoided. So again, barbiturates or phenytoin usually provide adequate treatment for eclampsia. So in babies born to myasthenic mothers, transient myasthenic weakness can be there even if the mother's myasthenia is well controlled. Usually it's self-limiting. And so we just need to deliver in a place of neonatal ICU so that we can monitor and optimize it when the patient has myasthenic crisis. So coming to an important topic in the 2020 update, they have emphasized on this called immune checkpoint inhibitors. Now we'll be reading what are immune checkpoints, what are immune checkpoint inhibitors, and what are the recommendations in such patients. So they are nothing but they control an immune response. They keep an immune response under check. called immune checkpoint. So they are present, they are expressed on the surface of T cells. So when there is an immune response to a foreign antigen, to keep it under check and to avoid damaging your own body, there are these immune checkpoints are there which keep it under control. So there are some immune checkpoints, like the most common ones which the treatment, the inhibitors are targeted against are CTLA4, which is cytotoxic T lymphocyte associated protein 4. We have PD1, programmed cell death protein 1, and PDL1, programmed cell death ligand 1. So what does the CTLA4 do? It reduces T cell activation. What does PDL1 and PDL2 do? Reduce T cell proliferation. That's all in simple terms. Avoids T cell activation and avoids T cell proliferation. So now monoclonal antibodies are targeted against this. They act by blocking this inhibitory response. So these are supposed to protect our body from the immune response. So by blocking them, what are we doing? We are, so the immune response becomes uncontrolled. There's nothing to control it. So these include ipilimumab, which is a CTLA4 inhibitor. PD1 inhibitors are pembrolizumab, nivolumab, and cemiplimab. PDL1 are atezolizumab, durvalumab, and avelumab. Mechanism of action, simple: upregulation of immune response, multi-system immune-related adverse events happen. So a lot of adverse events, it can affect any part of your body, including your skin, thyroid, lung, colon, liver, kidney, and also multiple neurological disorders have been found, in where myasthenia gravis is one of it. So in simple words, when you give an immune checkpoint inhibitor, patient who has already had myasthenia gravis, that can exacerbate it. Patient who has not had myasthenia gravis, in them there might be a new onset myasthenia gravis, or patient who has had a subclinical myasthenia gravis can manifest. So these are the three. So onset or exacerbation varies in the severity, and so usually these are very severe. When the myasthenia comes, it is very severe. Around 45% require respiratory mechanical ventilation, and they go into respiratory failure. And the onset is within 4 weeks of giving the treatment. Sometimes these myasthenia gravis may be associated with myositis or myocarditis or pericarditis, so making it very hard for us to diagnose the patient is having myasthenia gravis at all. So, or that can also be a triad. Patient can have everything: myasthenia gravis plus myositis plus myocarditis. So again, the other issue with this is why it is difficult to diagnose is they can be seronegative. They can have seronegative myasthenia gravis, and patient on chemotherapy itself is going to complain of generalized fatigue and difficulty walking otherwise also. So it's very difficult to diagnose. If you can either see AChR antibody positivity coming after treating them with this, or that can patients who already have myasthenia gravis can have a twofold rise in AChR antibody titers. So yeah, okay, de novo myasthenia gravis, that is new onset, has been seen with anti-CTLA4 and PD1 and with combined therapy, more so with combined therapy. And frequency of myasthenia gravis among patients treated with PD1 are close to 0.2%, 0.1 to 0.2%. Exacerbation of pre-existing is seen with PD1. So new onset can occur with either CTLA, PD1, or both, a combined therapy, and exacerbation is seen mostly with PD1 inhibitors. Now, what are we going to recommend? It's not a contraindication in patients with myasthenia gravis. There's no contraindication. It's just that we have to monitor. So we need to explain. First, the risk of myasthenia gravis and other immune-mediated neurological illness should be discussed with the patient, and whether should we test for AChR antibody before starting these immune checkpoint mediators? No evidence. No evidence to either support or refute the utility of testing. And in these patients, it's very severe and high rate of respiratory crisis, close to 40%. So, and the onset is around 4 weeks. Early aggressive, so we treat it aggressively with steroids, plasma exchange, or IVIG. So the decision to withdraw ICIs, that is immune checkpoint inhibitors, is determined by their oncological status, not by their myasthenic status. So pre-existing myasthenia gravis do not constitute an absolute contraindication, at least in patients with well-controlled disease. So, however, in a patient with well-controlled disease, minimal status are better. What do we do in such patients? Do we like it because it's controlled? Should we just go ahead? Not like that. In such patients, avoid combined therapy. Then clinical monitoring is required regularly with for respiratory and bulbar function. Third thing is we have to put them on immunosuppression, irrespective. So even though the efficacy of immune checkpoint inhibitors is less in immunosuppressed patient, we should still proceed with treating them with immunosuppression. Now coming to novel therapeutics, which is, so again, this is just a mechanism to one that can be just to like review is that can be blockage in ACHR cluster, reduce binding, internalizing, and membrane damage are the four mechanisms that happen in myasthenia gravis at the postsynaptic membrane. So this is what we'll be talking about. B cell depletion. So the new therapeutics target T cell, B cell, complement. And the fourth thing is the antibody itself it's targeting, neonatal FC receptor inhibitor. We'll come back to this after we discuss further. So now coming to B cell directed treatment, we have two. One is CD20, the other one is CD19. The CD20 one is rituximab, CD19 one is inebilizumab. So the rituximab, it's not FDA approved. And this has already come in our consensus and guidelines itself. So it says it should be used as an initial immunotherapy in MuSK positive status and after failure of other immunotherapies in ACHR antibody positive status. These are the some of the trials. This is the trial which has they have found that there is no steroid sparing effect in ACHR antibody positive status, BEAT MG trial. But the thing is, this trial has a lot of issues, like they have taken mild patients predominantly into consideration. And there is a review study which in MuSK antibody positive patients, they found that there is almost 58% of them have met endpoint. The endpoint is an improvement in an ADL, MG-ADL score. So inebilizumab, there is a phase 3 RCT going. This is a anti-CD19 monoclonal antibody. It targets pro-B cell, plasmablasts, and plasma cells. So now this is the phase. So the T cell, because of an antigen presenting cells stimulate the T cell stimulates B cell, there is antibody formation, and then complement activation and membrane attack complex and destruction of membrane. So these are the levels at which it acts. So B cell acts here. Now coming to complement inhibitors, we've spoken about eculizumab. So there are a couple of trials I wanted to mention. REGAIN trial was a primary trial based on which this FDA approval was based on. The thing is, they didn't meet a primary endpoint, but then they followed up they did a post hoc analysis and they followed up these patients met secondary endpoints. And then that is at 52 weeks, they found out that the patient had improvement in their activities of daily living. And then they extended the study for 3 years and they observed the patient and then found out significant improvement and the effect lasted up to 3 years in such patients. And since the benefit is seen as early as 1 week, the role in myasthenia crisis is being studied. So this is a monoclonal antibody that inhibits C5 here and avoids formation of the membrane attack complex. So C5 cleaves to C5A and C5B, then combines with C6, C7, C8, and then forms a membrane attack complex. So ravulizumab. So this is, we'll be talking about the dose that has been used in these studies as well. So this complement, eculizumab was given subcutaneous once in 2 weeks. Then there came another, which was built up on the backbone of eculizumab called ravulizumab. This is given once in 8 weeks. This is now FDA approved in April 2022. They are also long-acting C5 complement inhibitor. A phase 3 champion trial showed out significant improvement in ACHR antibody positive patients. And again, this also needs to be studied in myasthenia crisis because benefit here also has been seen in week 1 and was sustained up till week 26. Now, zilucoplan is not a monoclonal antibody. It's actually a protein. It's a peptide. It's a small 15 amino acid macrocyclic peptide which binds to C5. Now, these are all infusions. This is a subcutaneous administration, and the trial the regulatory submission to FDA has been accepted. And phase 3 is going on still though, but whatever preliminary study they have assessed, primary and key secondary endpoints have been met. So now this is an important and interesting topic called neonatal FC receptor antagonist. What is an FcRn? What is a neonatal FC receptor? So it is actually plays a central regulatory role in humoral immune response. That is, these IgG antibodies that are there, it protects them. So these IgG antibodies that you see, the pink ones, are prone for endocytosis, lysosomal destruction. What happens here? So now what does this FcRn do? It goes and binds to them and protects them. So the ones which are attached to the FcRn go back exocytosis and go back into the blood circulation, whereas the ones that are not attached get into degradation. So what antagonists do? They block these. They're blocking the FcRn. So all these antibodies are unbound. Everything gets destroyed. So the antibodies against AChR receptor positive antibodies, or any antibodies for that matter, get destroyed. So the blocking of FcRn promotes breakdown of IgG antibodies.
They're not increasing the breakdown, no?
No, whatever is that, they are increasing. So they're supposed to protect, but they're not. The receptors are occupied, so they're not protecting anymore. So they get destroyed. This is another drug. This is the first prototype drug which has been approved in the FcRn antagonist group. That was efgartigimod alpha. It is approved in December 2021. Again, so the antibody which which comes into play in AChR receptor antibody positive patients are G1 and G3, whereas in MuSK you have G4. So this targets most of them. Whatever is there currently is targeting G1. There's only one which targets G4. Here, so since G1 fragment has been targeted, it's into play for IACHR receptor antibody Myasthenia gravis. So these are the couple of trials. This is the first trial which proved its efficacy. Then they wanted to see how long the efficacy lasts, so they did an ADAPT plus. Then ADAPT next is they are tried different dosings. As of now, there are 4 infusions, weekly infusions that they have tried in this regimen. 4 weekly infusions. Now there is a long-term single-arm open-label multi-center trial which is studying subcutaneous injection, how that is working in generalized myasthenia. This is the one. This is razanolixizumab, which is a monoclonal antibody which is subcutaneously infused for FcRn against IgG4. So basically these are so FC, what these components, no, they are basically FC fragments. So FcRn binds to FC part of IgG4. They have an FAB and an FC component, right? So the FcRn is going to go and bind to the FC part of these antibodies. So they are creating molecules which are very similar to the FC fragments so that they block these FcRn receptors. There is a phase 3 mycarin G study for AChR called the mycarin G study, which is studying AChR positive and MuSK positive in AChR antibody positive and MuSK antibody positive. So primary and secondary endpoints have been met. They have been approved in June 2023. It's approved for AChR too, not for MuSK. June 2023. Then we have batoclimab, nipoclimab phase 3 studies are going on. Both are human IgG1. Now coming to T-cell directed treatment, very simple. This is interleukin 6 receptor antibody, like your tocilizumab, which we used in COVID. It is going to act on the start itself and avoid T-cell stimulation on the whole. IL-6 is supposed to start the response. IL-6 is supposed to stimulate T cells and T cells go to B cells, like that. So this humanized monoclonal antibody binds to IL-6 receptor, inhibiting IL-6 signaling and T cell activation. So there is a phase 3 for satralizumab and phase 2 for tocilizumab going on. Now CAR T cell therapy is an interesting therapy. So what they have taken is, they've taken autologous T cells. They've grown autologous T cells. They've taken it, they've modified, they've added something called a chimeric antigen receptor. These are specific antigens, antigenic receptor, which targets specific antigens in the body. Now we have something called DesCAR-T08 and inhibits it. these are autologous T cells with CAR, and that is chimeric antigen receptor, which targets B cell maturation antigen found on plasma cells. So the plasma cells don't go ahead to form antibodies at all. They block them. So, okay. So just to revise, so at the level of T cell, we saw satralizumab and Descartes. Basically, Descartes is nothing, a T cell which is going focused specifically on B cell. So B cell depletion, we saw CD20 and CD19. These are FcRn, which is going to enhance the antibody removal called efgartigimod, rozanolixizumab, and batoclimab, and nipolimab. So, and complement inhibition, you have eculizumab and ravulizumab, which are C5 monoclonal antibodies. Zilucoplan is the peptide. So, just eculizumab has been tried 900 mg weekly for 4 weeks, followed by 1200 mg every alternate weeks. After that, first 4 weeks they've given 900 mg, but so here major safety concerns are in Neisseria meningitis, and vaccination needs to be given 2 weeks prior to the initiation. Zilucoplan, same thing. In both we have AChR positive generalized myasthenia gravis, but zilucoplan is a subcutaneous that can be given. It's given 0.3 mg per kg. Again, same concerns of meningitis. Ravulizumab, also the same thing. It's a weight-based therapy, once in 2 weeks, 2,400 to 3,000 mg. But this is also an IV infusion. All these are the complement inhibitors. Now, efgartigimod is an FcRn blocker, again used for AChR positive generalized myasthenia because it targets IgG1. There we have given 10 mg per kg weekly. So 4 infusions weekly has been tried. Nipocalimab, rozanolixizumab, all same. And then what I wanted to show. These are other therapies that have been studied but have become like obsolete. So this was a study based on a study that was done based on on what is that? An article which was published in 2020. After that, a lot of they have been found not useful. Thank you so much.
Thank you very much. Very good presentation. Lot of new learning points. Yes, especially the FCR and CAR T cell. So any doubts, any questions? So ocular myasthenia protocol.
How to give a bilateral treatment, sir?
The criteria that it has to stay ocular this long to be called ocular, leather is not leather.
3 years.
So 2 years or 3 years. And this thymectomy, when do you start seeing the effects, beneficial effects?
12 months.
Somebody said 2 years. Okay. Ocular myasthenia protocol.
Give the bilateral treatment.
So first is bilateral
treatment. Yeah. See for 2 years whether there is any progression to general.
So even during the 2-year period, if they're not responding to bilateral treatment,
then only prednisone.
And steroid sparing agents, not much evidence.
Not much.
And not usually used.
Used. Ocular myasthenia, according to this, they can use it.
If it's not
Steroids also not working, then you can use it.
And then in some patients, you can even cut the
thymectomy if debilitating. Effects are debilitating.
Okay. Then generalized myasthenia?
Generalized depends upon based upon the acetylcholine receptor and the musk. If the patient is having acetylcholine receptor antibody, start with the bilateral treatment initially, then soon introduce corticosteroids. Then after corticosteroids, continue corticosteroids for at least 1 year. Then start as early as possible corticosteroids.
Till you get control over the symptoms.
Then steroid sparing agents have to be as early as possible. Then after the remission, try to withdraw the steroids first. Then the
steroid will be withdrawn when the patient's symptoms are under control.
Remission.
Steroids
or minimal.
Remission is what? Symptoms are not there.
Symptoms are not.
Then you try to withdraw the pyridostigmine and see whether they can stay without pyridostigmine. Then
The
withdrawal
withdrawal
steroid.
protocol is first you have to withdraw pyridostigmine, then the corticosteroids, then the steroids.
Minimal
Steroid.
effective dose.
You did not discuss much about withdrawal. How do you decide when to withdraw?
Sir, I
Clinical,
discussed.
electrical, immunological,
Clinical.
only clinical.
They are
What if
mentioned
they
on clinical.
continue to be AChR antibody positive?
That's what we need to opt for. If generalized with or ocular with AChR antibody positive, affect thymectomy.
What that is done. Now the patient is still AChR antibody positive.
That's
There are no symptoms.
only clinical. We need to look at only clinical aspect. Minimal manifestation is the goal. The goal of these consensus is minimal manifestation status with a CTCAE adverse events of type 1. That is minimal
the
type.
treatment objective.
Treatment
Now, once you
objective.
reach there, can you withdraw?
Minimal manifestation and remission are the two guidelines to when you start withdrawing.
Is there any role for monitoring antibody titers? Are they used only for diagnosis or is there any other role?
It's used only for diagnosis, sir.
In ocular, they tell that the patient is have persistent antibody titer.
There are chances to progress to generalize more, but other than that,
What if you're
monitoring.
doing quantitative analysis and when you're reducing the medicine, the antibody level starts to go up? ऐसा कुछ है?
No. Even if it does go up, it doesn't matter. Clinically, only we need to assess and treat the patient.
Would you continue with your withdrawal or you would say, okay, something is happening, I will not reduce?
No, I will continue with withdrawal. Clinically, if there's minimal manifestation status, I think I proceed with withdrawing.
What was your answer to Sir's question about symptoms are ocular, but findings are electrical findings are elsewhere also?
You have to treat as generalized.
Generalized
See,
myasthenia.
that is actually generalized myasthenia.
Yeah, generalized.
Because that electrical test is just one of the extensions
Criteria
of
for
Clinical
the
evaluation.
You're trying to show that there is fatigability in the muscle. Clinically, it's manifesting in the eye, but electrically, it's also showing in the other muscles, so it becomes generalized myasthenia.
And for generalized, steroid should be 100 milligram on alternate days. So it's right.
2
1
up to.
mg per kg is what we follow.
Up to. Slowly escalated, maximum dose is 100 mg.
On alternate.
On alternate.